Good morning. Welcome, and we want to thank everyone for coming today. I'm Steve Love, President, CEO of the Dallas-Fort Worth Hospital Council. And as you know, we do educational events, and we're delighted. One of our associate members, Gerber, has got an excellent program that we're going to have today. And the economic burden of allergies and positive patient outcomes is very important. And I think most people may or may not realize the importance and the good work that Gerber does associated with infants, allergies, food, etc. And we want to especially thank Gerber for their support that they've given the hospital council. As you know, a couple of years ago, we did an initiative at the request of Dallas Mayor Mike Rollins called Growing Little Minds. And that's where we put a real emphasis on brain development in the first 18 months to 3 years of a child's life. And Gerber was very supportive. In fact, they were even represented at the press conference that we had with Mayor Rollins. And this was part of the Grow South Dallas Deal with the Social Determinants of Health. And I am glad to say that the video that we produced, many of the hospitals are showing it still in labor and delivery about stimulating reading to your child, sight, sound, smell, all the different senses, and how if you focus on that, you can help the infant's brain grow. The other thing, and this is something that I just want to commend Gerber for, you know, as things change in society, I think it's important that good corporate stewards also look at what's going on socially. And Gerber this year, as you know, has contests where they have pictures of the baby that they put on their baby food. This year, first ever, a Down syndrome baby is on the Gerber products. And I just personally want to thank Gerber for doing that, and I think it speaks volumes about the personality, which to me, the personality of Gerber is their corporate culture. And that's important. With that said, we're delighted that we've got quite a few representatives from Gerber here today, some from out of state, some here locally. I think we all know Chelsea real well. She does a good job locally, but we're delighted to have the guest here. And it's going to be my pleasure to introduce the Medical Sales Director, Deborah Woods, who has worked with Gerber for a number of years, and she achieved a global training and certification. She's also a critical care registered nurse and a very valued friend of the hospital council. I think she and Chris Wilson have each other on speed dial. But she has played a major role in coordinating today's event. So Debbie, I'm going to turn it over to you.
Thank you so much. I just want to say thank you to Steve and to Chris and Jordan. We absolutely really appreciate the relationship that we have built and the things that we're going to do today and in the future, and you know, just for all the babies in the world. So I'd like to just introduce to Denise Wilson. She's the VP of, or Vice President of Sales of Gerber, so she's here today with us. So thank you very much for always supporting us. And then there's other people. I think there's people out there that will be coming in. But our keynote speaker is Dr. Andrea Papamanjaras, and she actually has a bachelor's degree in nutrition. And after she got her bachelor's degree, she went into and got her PhD, because the bachelor's degree is just not enough for her because she loves science so much. So she's got her PhD in dietetics and in nutrition as well. And she got that at Toronto, and then the other one, McGill University. She actually heads our scientific medical affairs department. She has a cross-functional team that she works with They put together a lot of scientific platforms for us. The platforms include childhood obesity, allergy, and other things that are related to children and maternal nutrition. So today I'm really proud and excited to introduce my friend, my colleague, and somebody that I learned something from every single time I'm with her. So Dr. Andrea Pimentel. Thank you.
Good morning, everyone. So I'm so glad you all came out this morning. What a wonderful introduction. I know that for our Gerber team, our relationship here with Steve and with Chris is really important. And most notably, I think, Steve, you captured it so well in terms of our hopes and desires really related to growing little ones and growing little minds and helping them start off on the right foot. I have responsibility over North America and up in Canada, where I spend probably more of my time up in Toronto. We also have the opportunity to work from the first 1,000 days, which is conception, up to 2 years. We also have a lot more opportunity there to work from a maternal perspective. So we really span that first 1,000 days, and it's really, really important to us. And I love that I get to come to work every day and think about nourishing that next generation and helping nourish those babies. My PhD wasn't about infant nutrition, so I get to learn each and every day, and I do not do what each of you do, which is work front lines with those moms and dads and caregivers and those babies. So I get to learn something every time I go out and talk, and I get great questions, and we have a small intimate group, so if you have questions about a slide, please feel free to let me know, or we can save our questions till the end. And really today, really it is about those positive patient outcomes. That's really what we're focused on. I think it's something that probably unites all of us in what we do every day. And ultimately, from our perspective, Debbie mentioned our platforms, really thinking about allergies. There is an economic burden there, and really that first feed. So let's take a look at our objectives and understand what we're talking about. So ultimately for today, I want to, and I think I say establish breastfeeding as the gold standard for infant feeding. I'm fairly certain we don't need to establish it. I'm pretty sure everyone in this room is well aware of that gold standard, but we'll just cover off some of the information related to that. And then that hierarchy of infant feeding. So really thinking through, for those infants who are not exclusively breastfed, what does that feeding choice look like? Then ultimately we'll drill down a little bit to discuss the impact, prevalence, and then who's at risk for developing atopic dermatitis. Really is that first step along those path to allergies as we think about all the impact, what comes after that. We'll just outline quickly the clinical evidence for atopic dermatitis risk reduction. Won't spend a lot of time there, but just to capture why it's so important. And then really that economic burden. So I think we have a diverse audience in terms of folks' backgrounds. So if I'm going too deep, stop me. Not deep enough, please let me know as well. So as I said, I think we're all well aware breastfeeding really is that gold standard of infant feeding. It's the ideal way to nourish an infant. It gives benefits for the mom and the baby in terms of really the baby nutritional, psychosocial, some functional benefits as it relates to breast milk, and really part of what we're talking about today, the immunologic benefits as well. So when we're talking that through, really breast milk is fascinating. It adapts to the needs of the infant throughout development, ultimately easy to digest, set up to be so by Mother Nature throughout the course, has those immune-related components, and really helps develop a healthy microbiota. We're not going to spend too much time talking about today, but that's another really exciting area. Probiotics and prebiotics, and if we had any questions at the end, maybe we can get to that at that point. But really, I like to anchor this thought, really, when we think about the WHO and then all the other work, that really no breast milk substitute will get to that level of sophistication and nutritional balance if we're thinking about an infant formula. So it's important to understand that, and then it's important to really understand how we can do everything we can for those non-exclusively breastfed infants as well. As I think many of you know, breastfeeding really does help lower the risk of developing certain conditions. Ultimately here we've grouped them: respiratory, gastrointestinal, and in other. The evidence for each of these things listed on the slide does differ. So there's not the same strength of evidence for each of these particular conditions, if you will. And you'll see I've highlighted in green atopic dermatitis because that's the one we'll spend a bit of time talking about. But this is from Pediatrics in 2012, and if you have interest to look at that. But there's obviously lots and many publications related to this. Most likely you're all familiar with expert recommendations related to breastfeeding. We've got the WHO captured on the slide, really talking about that exclusive breastfeeding recommended for up to 6 months of age. And then with that continued breastfeeding for up to 2 years, we have the AAP listed on the slide, American Academy of Pediatrics, again, up to about 6 months. If you take a deep dive into AAP, depending on who you're looking at, Breastfeeding Committee, Committee of Nutrition, you might get that 4 to 6 months, and then there's conversations about introducing complementary foods at the right time. So that's another interesting conversation. And then the AND as well, the Academy of Nutrition and Dietetics, also supporting that exclusive breastfeeding. So I think we're well aware of that, but I always think it's important to take ourselves back to really what we are striving for in helping moms and caregivers make those choices. Here I just wanted to capture that US breastfeeding report card. So this data is up to date as of 2016 coming out of the CDC. We had the 2010 objectives. Those are now, we have the Healthy People 2020 goals. You can see what the goals are in terms of any breastfeeding, ever 6 months, 1 year, exclusive breastfeeding. I've got in the middle column, we can see the current US stats, and then we've got Texas just on the right. So I think we're on our way, and each year it does seem that we see a little uptick every year, which is great. So we're not moving fast, but we are moving in the right direction, which is really, really important. And I think we can all be excited as it relates to that. So then I did mention the hierarchy of infant feeding because I think it also is important to acknowledge that breastfeeding is the best way to nourish an infant. After that, we can move down the hierarchy. This comes from the AAP and the Academy of Breastfeeding Medicine, down to expressed milk, expressed breast milk, donor milk ultimately reserved for those premature infants, I would say, but nonetheless recognized a part of the hierarchy. And then ultimately, infant formula, and as we know, the AAP does recommend iron-fortified infant formula for those infants who cannot be exclusively breastfed. So important to understand that this is a really interesting and exciting area of research as well. So then if we think about that infant formula section for a moment, and we think about the principles for developing an infant formula, from a Gerber Nestle perspective, we really align to this, that infant formula should only be used when medically indicated and or when exclusive breastfeeding is not possible. And obviously that can include mom's choice as well. And I do think it's important to acknowledge that. We want to do everything we can to help moms nourish their infants in the way that they choose to do it. And this is another really critical point. We should primarily seek to provide evidence-based functional benefits which minimize the complications that result from not exclusively breastfeeding. So ultimately, we're looking to exclusively breastfeed. If and when we do not have that option for infants, there will be potentially complications that arise. Our objective, our goal is to recognize there are complications and do everything we can to reduce those complications. So that's how we look at our role in terms of infant formula development. So now let's take a step and think about the impact and prevalence of atopic dermatitis and how it plays a role in infant formula development and why we do what we do on a day-to-day basis. So thinking about allergy and infant formula, ultimately, allergy is the most common immune disease associated with cow's milk protein in infant formula. So allergy is critically important. And atopic dermatitis is that most common allergic disease of infants. And if we look at this slide, we can see the prevalence is increasing as it relates to atopic dermatitis, 2 to 3-fold over the past 30 years. And almost 1 in 5 infants will develop atopic dermatitis by 6 months of age. So if you really take a minute and think about that, that's a really important condition to consider as we're thinking about nourishing these infants. And Steve mentioned, we're really trying to grow healthy minds. That is led part and parcel by making sure that we're doing everything to grow these healthy bodies. Ultimately, I'm sure you're all familiar with atopic dermatitis, the signs and symptoms, the rash, the itchiness. ultimately that distress and irritability. And really, it does significantly affect the quality of life of the infant and of the family. Many of the papers will do quality of life surveys with the parents when they're looking at atopic dermatitis, and you really see that there is a challenge related to this condition. So some folks think, oh, it's just, just some issues with the skin, but it can really affect those parents and those babies. And if I was very fortunate, none of my 3 children had atopic dermatitis, but if you've had or taken care of those infants, it can really be a challenge. There's also a huge impact on healthcare, which is really important to understand. In terms of, if we think of children from 0 to 18 years of age and think about this was a period of time from the late 90s. The capture was from, I think it's 97 to 2004, 7.4 million visits. Think about that for atopic dermatitis. The related costs from, and again, this is that broader age group, ranging from 364 million as a conservative estimate to 3.8 billion if you're thinking about all those different costs. We'll get into our health and economic assessment in a little bit in the presentation, but this is thinking about all those costs of the treatment itself, getting those kids to those doctor visits, etc. And really, that annual cost per patient per year overall estimated at $787 to $991. So I said we'll get into our assessment looking at infant formula in a bit, but those are big, important numbers for a healthcare system that's already under stress, I would say. This slide is important, and it's important to understand exclusive breastfeeding reducing healthcare costs associated with atopic dermatitis. So this slide is really looking at if we incorporated exclusive breastfeeding, these are the potential cost savings. So if up to 80% of infants were exclusively breastfed for 6 months, we're looking at those cost savings. If we were able to bump that up to 90% of exclusive breastfeeding, look at that number. I don't even know if I can say that whole number correctly in terms of over $600 million. So that's if we were talking about exclusive breastfeeding. As we know from looking at that report card, it's important to understand what the formula feeding rates are as well, because as we're going to see in a little bit, that's also affecting cost. And there are things we can do to reduce cost as it relates to making infant formula choices. And more importantly, making infant formula choices to reduce that risk and that effect on those babies. The other thing to understand, and I think many of you in this room would know this as well, really that allergic march theory, progressing from atopic dermatitis all the way up through to allergic asthma and those types of things. This is something that if we can reduce the risk and have less infants have this condition, hopefully overall we're going to be reducing the impact on their health, and then also the impact on our economics and our healthcare system if we're able to reduce the risk of developing these conditions, which I think is also really critical to understand. So ultimately, we do talk a lot about infants who are at risk, and much of the research is done in infants who are at risk for developing allergies, because we're able to identify these infants. And how do we do that? We do it through family history, and this is critical to understand because, as I said, a lot of the research is done in these infants with a family history. It's a really straightforward thing to do. You ask questions: has a biological parent or a biological sibling had allergic rhinitis, asthma, atopic dermatitis, or food allergy? If the answer is yes, then that infant is at risk for atopic dermatitis and allergies. And so if we think about what I said, exclusive breastfeeding can really help reduce the risk of allergies. So this is a really important thing to think about. If we can get more babies to be exclusively breastfed, then we can be reducing their risk and hopefully helping them reduce that risk of developing atopic dermatitis and ultimately allergies as well, based on this information. So if we think about, as I mentioned, infant formulas and atopic dermatitis, we've said this before, breastfeeding really is the best way to reduce that risk. Can we reduce atopic dermatitis risk in non-exclusively breastfed infants? So we talked all about the importance of breastfeeding and breast milk. What can we do for those babies who are not exclusively breastfed? As I think you would know, infant formulas are not all the same. and a critical piece of an infant formula as it relates to development of atopic dermatitis has to do with the protein source. So all infant formulas develop and deliver adequate nitrogen. So we have casein, whey, a whey-casein ratio, and soy. But it's important to understand that they do not behave all functionally the same. And I'm just going to show you a bit of that, touch on that data a little bit. But what do I mean? So if we're thinking about infant formulas, and I talked about protein, and I think we're well aware that if we take a protein, and as highlighted in this slide, we start to break down the protein into smaller pieces, we may potentially decrease the allergenicity and or tolerize the immune system to not necessarily recognize that protein as foreign and not necessarily cause that potential for an allergic reaction. So if we think that through, if we take a higher molecular weight protein and cut it up, we may have that reduced potential for an allergic reaction. So it's making the protein smaller, and it's also understanding the type of protein that we are using as well and starting from. So as highlighted on this slide, from an infant formula perspective, we can take intact whey protein, and I talked about the different sources of protein in infant formulas, but there's a unique protein hydrolysis process that takes intact whey protein, uses heat and enzyme in a very specific process, and takes that whey protein and makes it into smaller sizes, from 12,000 Daltons to around 1,200 Daltons. And this is driving the effect of those infant formulas on the immune system and ultimately atopic dermatitis if you think about that reduction in allergenicity. And again, this just highlights that. You can see on the left-hand slide, it's just an interesting picture that suggests when you have those smaller peptides, and hopefully you can see it up on the screen, there's a small peptide with the little amino acids depicted, and we get far less of a reaction versus the larger peptide that then gets into that whole histamine release within the system and sets off that allergy cascade, if you will. And ultimately, as we know, once an infant is exposed, then that sets up that allergy cascade moving forward. So in terms of understanding the evidence for atopic dermatitis risk reduction, so we talked about there's breastfeeding and there's breast milk. Then we said, okay, for those infants who are not exclusively breastfed, if they're getting an infant formula, what data and information is available to reduce that risk? And ultimately, I don't have my glasses on, so I don't know what that little thing says there. 1 second. Did that pop up for you guys or no? There we go. My apologies. There we go. So I won't spend a lot of time going through the evidence right now, but what this slide shows us is that partially hydrolyzed whey protein may reduce the risk of atopic dermatitis in at-risk infants. So you can see that an intact cow's milk protein formula, where the protein has not been broken up, highlighted in the orange, there is a higher cumulative incidence of atopic dermatitis in comparison to that hydrolyzed whey protein formula, which is very specifically hydrolyzed as it relates to heat and enzyme. So that is a large bulk of data. I would also highlight, this represents what we call the Geni Study, or the German Infant Nutritional Intervention Study. This was one of the largest randomized clinical trials that was done looking at infants fed this partially hydrolyzed whey infant formula versus that intact cow's milk formula. And again, up to 15 years of age, it is showing that there's a reduced risk of atopic dermatitis for those infants who are fed that 100% whey partially hydrolyzed versus intact cow's milk. So I just wanted to make sure that we were a little bit grounded in the clinical evidence for this as we think through reducing this risk. There's a lot of clinical evidence, published studies, meta-analyses, systematic reviews, and I'd be happy to discuss those if anyone has any questions, but just wanted to make sure that we grounded ourselves in that. So now as we think about all the aspects of healthcare and what we're all trying to do, it's really important to understand that we want to be focused on breastfeeding and nourishing those infants and helping those moms and caregivers and those families. We want to understand if infants are not exclusively breastfed, what can we be doing in terms of that first feed, making that first choice of infant formula matter, We talked about the clinical evidence for reducing that risk of atopic dermatitis as it relates to that first feed, and then how ultimately atopic dermatitis really can take us through that allergic march. So understanding the economic impact of AD is equally important. So what we did is we were able to use a health economics model and look at the economic burden of atopic dermatitis. I mentioned in those high-risk infants, so those are those infants we talked about with the family history of allergy, who received cow's milk formula or the partially hydrolyzed 100% whey-based formula. This was a huge opportunity for me. My background is not in health economics, so if there's anyone in the room whose background is in health economics, please feel free to speak up. But this is one of the things I love about what I get to do. This was a new area of learning for me, which was really excited. So I'm just going to take you through this a little bit to help understand this. Not only is the health impact of the first feed choice important, but the economic impact of these choices are really important as well. So the study question was, what is the U.S. economic impact of feeding infants who are at high risk with that 100% whey partially hydrolyzed, and that's what the PHFW stands for, instead of intact cow's milk formula, which is CMF, for those first 4 months of life. And we really look at those first 4 months of life because that's the period of exclusivity and the period that was looked at in many of the trials that we talk about. Ultimately, we were also looking at that impact over the first 6 years of life, because that is, again, where some of the other studies have looked at. And we went up to that 6-year period to understand that piece, because that's where a lot of the costs are driven and come in. And looking at that nutritional intervention to reduce the risk of developing AD and what is happening in terms of the economics related to that. And this study was funded in part by Nestle, Gerber. We work with a health economics firm who has the expertise related to health economics. We have some in-house experts as well, but we really do get support. So this slide just highlights the model. It's called a Markov model. There are different health economics models, but this is one of the more popular ones as it relates to doing this. We use different cohort techniques to simulate the incidence and the course of that atopic dermatitis. So this is all a simulated cohort. We're using real life evidence to feed into that simulated cohort. Then we look at the costs and clinical outcomes associated with developing atopic dermatitis within those first 6 years, and ultimately look at the impact of reducing this burden of feeding that 100% whey partially hydrolyzed formula versus the cow's milk formula in those first 4 months of life to understand what the result is as we think about economics. This slide is a little bit similar. This slide is just helping us to understand what are we looking at. So when we're thinking about the model and thinking about doing health economics, we need to understand 3 critical things. We need to understand the cost of the intervention. So the cost of the 2 formulas, so 100% whey partially hydrolyzed versus intact cow's milk, and so then also the incidence of atopic dermatitis within the population and what's happening. And then those treatment costs, because those 3 things are critical in terms of feeding them into the model that's highlighted in the middle, where we estimate the direct, and those are the costs related to directly treating that case, versus indirect, which are the costs related to parent time lost from work or travel time and costs like that, which are also very important to take into account. And you can see that those estimated direct and indirect costs look at reduced incidence, 14%. This is based on information from a U.S. physician survey, as well as that Geni data that I mentioned before. That's why that study is really important to help us understand the incidence. That U.S. pediatrician survey I mentioned, really looking at costing sources, market data, and expert opinion. So a lot of information gets collected to go into this, and then ultimately we estimate that economic impact. The next few slides I'm going to show you, I'm not going to go in depth in, because this slide really is the overview and the summary of this. But what these few slides show us is they do highlight the information that goes in. So I said the Geni study, we have that physician management survey information. We had to leverage our 2008 FITS data. So that's our Gerber feeding infants and toddlers study that I'd love at another time or during question period to talk to you a bit about. But what that data told us was the formula consumption. Because obviously, if we're going to estimate the cost of formula, we need to know how much formula these infants are taking in. So we were able to do that. Expert opinion, the Nielsen pricing. So the pricing was taken from 2013 in terms of understanding how much those formulas are. Again, more methods, information in terms of cost of the treatment, cost of the drugs, all that kind of stuff, the indirect costs that get associated. And then again, ultimately, if you're doing a health economics, just like you would do with any kind of modeling, you have to be clear on the assumptions. So again, I won't dive deep into this, but we made some assumptions about we would only look at formula up to 12 months, what kind of treatment we would look at, when the infants would get switched. So if an infant, if a simulated infant or a simulated case of atopic dermatitis would show up, how that would get treated. So all that information and these assumptions get put into this method of estimation. And I appreciate this is also a bit of an eye chart and a busy slide. But what this slide just helps you understand is we really go through the modeling of this to understand. So each of the different circles represents what happens at a certain phase. So on the left-hand side, you present with a case of atopic dermatitis, then you might get put on a certain formula. As you move through the diagram, there would be formula switches and potential treatment switches as well. This model gets run up to about 5,000 times to pull out the data and to do that simulation. So it's quite intricate and fascinating. And as I said, I don't do the modeling, I just learn about it, which is exciting. So really, another thing to understand is it's really considered to be a US societal perspective because we did include those direct and non-medical indirect costs. And ultimately, as I said, that 6-year horizon. When we think about the key modeled outcomes, we're looking at proportion of patients who developed atopic dermatitis, time spent post-AD diagnosis. This is just important to understand because once the simulated case of AD starts, that's when the cost starts, right? So we need to understand when on the spectrum, based on all the information we put into the model, that might happen. How many atopic dermatitis symptom-free days there are, because again, that's going to have less cost. And then the cost and clinical visits associated with that as well. And then the economic value of all that is happening. So in terms of results, so again, we're talking about those high-risk infants, and that'll be important when I extrapolate these costs across the US at the end in terms of what the authors did. There was an absolute estimated 14% point reduction in atopic dermatitis incidence for infants who were fed the 100% whey partially hydrolyzed versus that cow's milk, intact cow's milk protein. So again, this is simulated, but that's a huge difference already. 14% of infants less at risk. Ultimately, 39 days without an AD flare, again, simulated, but important to understand. And then reduction 8.3 months times time spent post-atopic dermatitis. So over those 6 years in the model, infants, there was less time spent post-AD diagnosis, meaning that based on the modeling, the children who got the intact cow's milk protein formula developed atopic dermatitis earlier. So that's not a real world scenario, but in the model, that's how this information gets generated so we can look at the costs. Again, and it's always important to remember this is not a real world case. So we're not suggesting that we're developing it earlier. And you can see those numbers highlighted on the slide in terms of that incidence, days without AD flare, and time spent post-AD diagnosis. Again, this slide highlights the overall total discounted cost. Discounting of the cost is another important factor in health economics modeling, and that's a term that's used. And this is over that first 6 years of life. So this is really important to understand that we're looking at a total cost of $724 versus $1,219 as well. And you can see that every year the cost goes up, and that is what that chart is highlighting, ultimately to that overall cost. So again, that's a big difference per simulated infant over that 6-year period. Again, when we think about the cost per incident of AD patient, regardless of type of formula fed. So the way this gets captured is we just want to understand the cost if you developed atopic dermatitis, regardless of what simulated formula your simulated infant was on, we're looking at $3,284 of managing that within the first 6 years of life. That is a really important number to understand. And imagine that if we were able to reduce that risk by exclusively breastfeeding or making a choice in terms of infant formula, that's a number that we could be bringing down. And then average annual undiscounted total cost is $787 per incident case. That's the annual. And the reason that the annual doesn't work out to the total is because the amount per year isn't the same across each year. So that's why the math looks like it doesn't work, but the math from the model works. And look at that, total annual number of visits per AD case was estimated to be 3.58. So again, if we were able to reduce that through breastfeeding or through infant formula choice, that's a big number. This is the slide that I really like to focus on, and I think for people who kind of got, glazed over a little when we talked about the health economic modeling, I think this is an exceptionally important slide to understand. And this is what the authors did in the paper, is they looked at this information and did this extrapolation to look at these overall costs. So in this, we are talking about what would be the cost savings per year if we looked across the US population. So I'm just gonna put my glasses on to make sure I get each of these boxes right. But we start off with that average annual direct and indirect cost. We talked about that at $787. Ultimately, we're doing this annually, so we need to look at reduction in the total time spent following an atopic dermatitis over a year. That's why it's that 8.3 months divided by 12, because we had to do it per year. Births per year in the US estimated at 4 million. Then we want to think about those infants who are not exclusively breastfed, conservative estimate at 52%. Then it's important to understand about a third of kids have that family history of allergy, so we take that number and do it at 31%. If we do this calculation, we estimate that if you fed infants who are not exclusively breastfed that 100% whey partially hydrolyzed formula instead of that intact cow's milk formula, we will be looking at $355 million cost saving per year. That's a huge number, right? I think that's really important to understand as we help these families and caregivers make these choices. We can also do the extrapolation as it relates to the atopic dermatitis related physician visits. Again, the calculation is fairly similar, right? Except we start with the annual AD physician visits at 3.58, which came out of the model. Again, we annualize it in terms of time post-diagnosis, births per year, not exclusive breastfeeding, and that family history of allergy. And we get to 1.6 million physician visits for something that we could really be thinking about helping through exclusive breastfeeding and formula choice. Again, a really powerful number. This slide simply captures stuff we've already gone over in terms of how we can really affect that healthcare system in society. We talked about the reduction in cumulative incidence and that the reduction in the cost of $495 per child. And again, that $355 million estimated cost savings per year, 1.6 million visits avoided. And actually, if you take a dive into the paper by Banagankar and colleagues, you'll see that from their perspective, these were relatively conservative estimates as well. And in the paper, they go on to look at, if you looked at all infants, not just those with a family history of allergies, you can extrapolate even further and the amount of savings go up even more. So why care about health economics data? As a nutritional scientist, as someone who's interested in really nourishing that next generation and nourishing those babies, why is this type of data important? Hopefully, I think as we captured the dollars and the visits, you can understand it's important. But it's really that connection point between clinical evidence and cost effectiveness. So from my perspective, I had that slide up with all those papers. That's where I spend a lot of my time, looking at the clinical evidence, understanding what's out there. But it's really important to understand the value of that and not just be looking at clinical evidence, in and of itself. I mean, I think it's really important, but we need to connect it to that cost effectiveness. So I think it is invaluable to society, healthcare systems, caregivers like yourselves, those healthcare practitioners, all that. And what's really exciting is it's another reason to have those conversations with parents and caregivers about their feeding choices. I don't think we need a lot of new reasons to be talking to parents and caregivers about exclusive breastfeeding and the importance of breast milk, but this is just another reason to say, hey, for those kids with a family history of allergy, let's really, you know what, let's get the lactation consultant, let's have that conversation. If mom's choice or exclusive breastfeeding isn't possible, let's talk about that formula choice and that first feed, because it can really make a difference in something that we think is pretty straightforward, which is atopic dermatitis. Because if we think about the clinical evidence and the health economic data, it's really concluding that if you think about that 100% whey partially hydrolyzed formula versus an intact cow's milk formula, we can really make a difference. So overall, I think I kind of captured it while I was on the other slide from a conclusion perspective, but breastfeeding, best way to nourish an infant. For those infants who are not breastfed, we want to reduce the risk that comes from not exclusively breastfeeding. That's really the paradigm that we look at this, and that's really what we're here to have those conversations about. Let's reduce that risk that comes from not exclusively breastfeeding, and let's think about the choices that we make. And I would say if we're thinking specifically about allergy and then atopic dermatitis, I think it's important to think about that first feed and the use of that 100% whey, partially hydrolyzed protein, hydrolyzed in a very specific fashion, because all the clinical evidence that I flashed up with those papers is looking at a very specific way of doing it, and it's important to understand that there's the clinical evidence related to that. And then also that reduced economic burden of atopic dermatitis, if we can help parents and caregivers make those choices versus that intact cow's milk protein formula. So for me, as I said, this is really exciting. It's another opportunity to have these conversations, and hopefully I've taken you on a bit of a journey as it relates to a little bit of the science and then the health economics of it all as well. So maybe you have questions or not, but thank you so much for your time. Hi.
Good morning. So, sorry I chimed a little bit late.
Please.
So my question is, are there any evidences looking into that, how it impacts immune system overall, whether those kids are more prone for other diseases too?
That's a great question. So the question is and so are you asking in terms of atopic dermatitis, what's it doing in terms of the immune system, what's happening after? So I think what we're learning, so there's something that is called the allergic march theory. And the reason it's referenced as a theory is because it's not always exactly possible to follow those cohort of exact kids as they go through, right? So if you have a child who's developed atopic dermatitis, we don't have big cohorts of following that exact child through as they grow up and their immune system grows up. But what we are seeing is that in general, if you're looking at a cohort, an overall cohort of kids, and you think about atopic dermatitis, they do go on to then develop allergic rhinitis and then asthma. So ultimately, it is potentially priming their immune system to see other things as foreign. So it's not all kids, but you start to see the percentages, kind of 60% of kids might go on to develop allergic rhinitis, 30% of those kids might go on to develop asthma. So it is really important to understand that the immune system, I always think of the immune system as windows, and depending on what you put through that opening or that window at a certain time, it's gonna prime your immune system.
And especially at this early age. So,
Yep.
So that's the reason I asked this question was because when you look at the health economics and looking at in monetary terms,
Yes.
then you see more impact on that side if
I think
immune system was compromised as well.
absolutely. So I think that's a really interesting point. So earlier on in the talk, I showed some data related to costing, and that was looking at that 0 to 18 age group, which was why those numbers were really big, because it was looking at beyond the 6-year period for atopic dermatitis. It was saying, okay, in the 0 to 18 age group, these numbers are really big, exactly to your point, and that was just atopic dermatitis, right? If we think about all the other potential immune-related disorders, then yes, if we think about treatment for rhinitis and then ultimately treatment for asthma, we don't have that data, but I think you can imagine that those costs are just gonna go up and up. I think that's the point you're making. Yeah.
It requires longitudinal trial then. But
Yeah.
As you show that 1.6 million hospital visits, so if you count all other
Yeah.
visits as well,
Exactly.
and if
Yeah.
that we see the impact.
Yeah, and I think it's really important to understand, and in the health economic paper that we did, the cost per physician visit ultimately gets estimated when they drill it all down. It seems like a small number to me, but exactly to your point, and if you think about health and everything we're doing and well baby visits, and if we sort of thought about there was more opportunity kind of for well baby visits and growing those minds like you talked about and having those conversations about other aspects of nutrition. As a nutritional scientist, I get really passionate about dietary patterns and who's eating what when and who's getting enough veggies and fruits, right? Like that's part of my world. And to your point, then those are the conversations we could be having too, right? Which is exciting. Yeah.
Actually, that used to be my world too.
Yeah.
I worked in nutrition.
Oh, nice. I think we have another question at the back.
Do you see any relationships to literacy?
That's a fantastic question. I'm going to be honest with you and say that's not my area of expertise in terms of linking conditions like atopic dermatitis with an outcome like literacy. What I can tell you, I mentioned the Geni trial, the German Infant Nutritional Intervention Study. They did look, so they've been able to capture that same cohort over time, which is fascinating. As I mentioned, you can't always get that big cohort, but they started out with those 2,200 plus kids. At the 10-year mark, so the Geni 10-year data, it does look at some of the, I'm not so much as cognitive capacity, but behavioral capacity anyway at that 10-year mark. And it is suggesting that the kids who had atopic dermatitis were at a slight disadvantage. So I can't speak directly to literacy, but I think, you know, if you were going to think about kind of what you're setting up those kids for and thinking about sort of that, those cognitive capacity, and I think actually in the 10-year data, there is a measure of depression as well. I could be wrong, but I think that's in that 10-year data, and I can look up the ref for you. Von Berg is the lead author, and it's the 10-year data that captures that. But again, you know, you think about growing those well babies and nourishing that next generation, you just want to set them up to be comfortable because that leads to so, it's just like nutrition, right? And I think there's another question.
Yeah, so what's the best time as you're working? You said in Canada you have a lot better opportunity to work with mothers as they go through the pregnancy.
It's only because we have the prenatal multivitamin and mineral supplement. So Gerber, Nestle does a great job. I just meant I have more of an opportunity to talk to obstetricians and gynecologists in Canada just based on the science we support. So, okay.
So, but what is the best time to try it from sort of a policy perspective? When should we be introducing this information to, you know, mothers or family members or others?
That is.
And you also talked a little bit about the cost differential between the types of formula.
Yeah.
It'd be interesting to see how that, you know, changes people's
Those are.
decisions if they don't have this full set of economic data.
So those are two really great questions. So I would actually put the question back to you as caregivers who are seeing a lot of these patients from a policy perspective, from a best practice perspective. You know, what would you all say? I would say, I mean, this is going to sound a little bit overly lofty, but I would say there's a lot of conversations we can be starting with our kids as we think about the next generation, right? So if we normalize the concept of breastfeeding and the importance of good nutrition itself and normalize breastfeeding, and we grow up these generations to think that of course mom should be breastfeeding when the baby's hungry, wherever they are, and that, so I don't mean to be overly philosophical, so I think we could have a slightly different conversation, but I do think that's a relevant point, and my point is sort of it's never too early, and you don't want to overwhelm people with info, but I would ask that of you, and you raised a great point, and I omitted to say that in the presentation. In the US, the intact cow's milk protein formula and the 100% whey partially hydrolyzed formula, which is actually our Gerber Good Start Gentle, just for clarity, and I do have a slide if anyone has questions about names of formulas, it's the same cost. So that's why in the US, this health economics model works and is so powerful because we're not asking caregivers and parents to spend more money to save others money at all. In other markets, it's different. Actually, in Canada, there's a huge cost differential. So it makes the health economics numbers look a little different, although even in Canada, it still nets out to be a better economic choice. But I love the policy question. I mean, I think that's a really critical point, right?
So is it covered under WIC? Because our facility works with a lot of low-income women.
So that is excellent question, and I am not an expert in terms of each state's contract for WIC. So I think Debbie, in terms of Texas, would know. I should know each memorized, but across the different states, if it's the WIC formula, then yes. And then I think there are some conversations starting to happen about if you have an infant who's at risk, has a family history of allergy, what does that look like from medical necessity? And I'm being purposefully provocative, so don't take that and run to the policy office. But I think it's an interesting question, but I'm not sure about the WIC.
Yeah, at this point, Abbott retains.
Yeah. So the formula and contract would be then the intact cow's milk protein formula.
What we do, there's extensive HA that we have for cow's milk protein allergy, and it is covered.
Yeah.
And I know that's a very highly used product for cow's milk protein allergy, so that's
Yeah.
covered 100% by WIC.
Yeah. But important questions. Steve.
Awesome, thank you.
You're welcome.
The question I have is kind of an unfair question.
Okay, I like that you let me know that.
You know, when you look at pharmaceutical companies,
Yep,
they do studies and they have their efficacy of drugs, et cetera, et cetera.
sure.
But if you have a disorder or a disease, many times you've got to buy the drug from Squid or whoever.
Okay.
Whoever produces it. When you look at the good work Gerber has done and the research you've done, you have competitors out there.
Yes.
Is there any collaboration among you where you share the data so that all people can benefit from it? Do you understand what I'm saying?
I think I do
It's
understand what you're
not-
saying.
It's not, Gerber has come up with this, but I don't know who your competitors are, but.
Yeah.
That they go, we're not gonna use that, we're not, because we don't want them to buy the Gerber product. And in the long run, the people lose.
I think,
So my point is, how do we share best practices? That's what I love about the hospital council. We have 90 hospital members. They compete like hell. They want each other's patients.
Yeah,
Let's
yeah.
get candy. But when they come to the hospital council, they look at patient safety, they look at what can we do that's best for the community, and they take those competitive hats off. It'd be great if we could do that in this arena.
you know what, I love your question, and I think it's a smart, provocative question as it relates to if we firmly believe in this and the clinical data is available, how do we work potentially as infant nutrition experts with our competitive hats off, if you will?
Exactly.
Yeah, I think it's a really interesting question. I would say, I think I have a two-part answer. So I would say my one-part answer is we do have opportunities where we can feed all this information to associations, if you will, that will look at this data. So for example, you can think about, and I didn't present the slide today, but you can think about the American Academy of Pediatrics, and that they do recognize that there may be benefit for partially hydrolyzed protein products, may be benefit. You can look at the association like the Quad AI, the American Association of Allergy, Asthma, and Immunology, and you can look at their guidelines and recommendations that also recognize that there is potential benefit in atopic dermatitis risk reduction using an infant formula with 100% whey, partially hydrolyzed protein, to reduce AD risk. So there are those association platforms. So I think people can leverage them. And I think that's really critically important. And we, as our competitors do, interface with those associations and have all that data to share and discuss. I would say from Gerber's perspective, from my perspective, I think we really do believe we are doing everything we can. And I would say the example in part is us coming here today, me sharing this data with you. Our infant formula, we support breastfeeding. We have a lactation consultant at our consumer care call line. We have a sleep consultant. We're really supporting those families and those moms. So we really believe in this and we support it. Our infant formulas are not more expensive. And it actually, truth be told, is more expensive to take that whey protein and hydrolyze it and provide it in that infant formula, but we believe in all access as it relates to that infant formula, and it's in all our healthy term infant formulas, this protein. So we don't have as many choices at shelf, in part, I think, Steve, because we're trying to do what you're suggesting, which is bring clarity to what we believe is the best in helping caregivers and moms and grandpas and grandmas get to that when they need infant formula as part of their feeding choice for their infant. Well, thank you. I think these are really great questions, and this is where kind of as that nutritional scientist and that scientist to me, I also get to dip my toe in the policy waters because I think it's really important. I think I can keep on going, but if any of you need to slip out, please feel free to slip out.
I don't know if you can answer this, but what would be the difference between a Gerber Good Start Gentle and a Similac Total Comfort, which are both?
I can answer that, absolutely. And so what I can definitely do is speak to our product. And this is a really critical point. So our product, so our protein, so in Gerber Good Start Gentle, and it's also in Gerber Good Start Soothe as well, we use 100% whey, partially hydrolyzed. I mentioned really briefly on one of the slides that there is a unique two-step process. So we use heat and enzyme to hydrolyze that whey protein. We do this actually around the globe, and the process itself is meticulously monitored, and the output, the protein that is the result of that process, also meticulously monitored. That protein, that 100% whey partially hydrolyzed that's in the Gerber Good Start Gentle, hydrolyzed that way is what has been studied. So that slide I showed with those over 20 papers, meta-analyses, systematic reviews, is the protein hydrolyzed in that fashion. What I can tell you is that I don't know how the protein in Similac Total Comfort is hydrolyzed. What I can tell you is that we did, and this may take you all back to your undergrad days if you were in science, you can look at protein sizes using an electrophoresis gel, like an SDS page. Does anyone remember? You take the exactly. And you can see, and what happens is the different protein sizes migrate through the gel at different rates, right? So what I can tell you, and then I invite you to have the Similac folks answer this question, because it's not for me to answer for them, but what I can tell you is the proteins look different. So there's a large protein that shows up on that SDS page gel if you run Total Comfort against Gentle that's not in ours. So I can tell you based on my assessment of that information that it's not the same, and that their Total Comfort is not able to leverage that clinical evidence. Unless, again, I haven't had that direct conversation with them, so they might be able to tell you differently based on what I've seen and I know. It is different. And it's really important to know that because, and if I can just take one more minute, because this is like my huge passion, but the Geni trial I mentioned, right? They actually, not thinking about partially hydrolyzed protein for a second, think about extensively hydrolyzed protein for a second, right? So you would think, I showed you that slide, if you chop up the protein, it's gonna be better, right? Oh, it'll be better. I've chopped up the protein, it'll be better. What happened in Geni was they looked at extensively hydrolyzed casein, which is what is used, was studied for cow's milk protein allergy. And they looked at an extensively hydrolyzed whey. This is where it gets a little confusing because it's not the same as the one that we have in extensive here. But those two weren't the same. So my point is just chopping up the protein isn't good enough. You have to know how you chopped it up and examine and study that protein. And that's why I'm so passionate about this, because I think it's really important. I think that's a really important question because I don't believe, based on the evidence I'm aware of, that they're interchangeable at all.
And I believe that the process that we used had a patent on it.
It did, doesn't anymore.
The patent expired.
Which kind of speaks to Steve's question, that if others wanted to do our process, they could.
But they haven't. And it goes to what Andrea said earlier, the cost of goods to make the products is higher for what we do with Gerber Good Start because we have 100% whey protein partially hydrolyzed, as well as we have probiotics in our formulas. So
Yeah.
our routine formulas are the highest quality for all babies, whether whey or non-whey. And that's
Yep.
organizations that really highlights the products that were studied and what they support. And there's a few competitive products listed.
Yep. Thank you. You guys I love your questions and your engagement. This is phenomenal.
We deal with clients who have low literacy in general.
Okay.
And so or do you already have literature that we can give just to the common person for understanding of why it's
That is it. Yeah, that's a fantastic question. And I would say, absolutely, it's important for us to help you all have those conversations with your patients. And I would think we have our online, like our website. So mygerber.ca is the website. And we also have, and I can't access this because my iPhone is Canadian, but we have a really great app. It's called Dottie. And I know one of my colleagues can help, but it's a place where questions could be asked and answered of a dietitian, and it's really neat and interactive. So I think,
if you give us your card, we would be happy to bring you a bunch of, or send you a bunch of brochures where you can hand those out.
yeah, because I do think I appreciate that it's a tough concept, but you want your caregivers and moms and everyone to feel empowered about the choices they're making, right? So.
And really anybody table that have Dottie information.
Okay, good. I'm so jealous I can't get it on my phone.
They're right outside on the table.
Yeah.
But if you want more, we'd be happy to give them to you. Happy to.
Yeah. You guys have really stayed the course. Thank you. So we might have one more question, or
If I can.
please.
And you may have covered this before you stepped in. So you put the kids on Gerber Gentle and you saw excellent results there. What is your recommendation, or is it in maybe one of the studies I need to go back and read? What is your recommendation for that next step after 1 year of age? Would you ignore, do you trial whole cow's milk, or do you consider to avoid it?
So really good question in terms of next steps. What I can tell you about this data, and as we're thinking about atopic dermatitis risk reduction, is we're talking about exclusive formula for the first 4 months. So the data as it relates to this topic is looking at that 4-month window of formula feeding. So I would say that's where, and that well fits in the AAP guidelines. Ultimately, if there's not exclusive breastfeeding, iron fortified infant formula is the next choice. One thing to think about, if we're talking about allergy and we're talking about atopic dermatitis risk reduction and we're talking about cow's milk protein, ultimately, if we think about the introduction of complementary foods, the proteins are going to start to come in through the introduction of complementary foods. So I would say it's very straightforward in terms of aligning to the AAP guidelines in terms of their introduction of milk, et cetera, because the immune system's going to start to see those bigger proteins once you introduce those complementary foods. So from an allergy or atopic dermatitis risk reduction perspective, not as relevant. I would say from a nutrient intake and overall dietary pattern perspective, as you would all well know, that's really important in terms of that milk introduction, whole milk versus lower fat milk, and then depending on if the family's at risk for obesity or not, and then we can get into all those kinds of conversations. But am I answering your question? Okay. Thanks. So thank you all for having me here today. This was really exciting. And I loved being able to come to Dallas. So thank you for that too. And have a good day. And then, as Debbie said, if you do have any questions or on materials, et cetera, there are some outside, or absolutely if you need to run, you can leave your card with Debbie or Chelsea or Lacey. And
Like grab anything that's out there
yeah.
right now.
Thank you.